It's my pleasure today to introduce Raquel Sabino, whom I know for quite a while now and whom I had the chance to have working in our lab for some time. Raquel has a degree in microbial biology and genetics from the University of Lisbon, and she joined us here at CBMA to do her PhD that was completed in 2010. And during her work, she developed and characterized new molecular markers for the identification of pathogenic yeasts, for the identification and diagnosis of pathogenic yeasts. Then, following the PhD, she went for a postdoc at the Californian Institute of Medical Research at Stanford University, California, where she consolidated her formation on medical mycology and had the opportunity to open new horizons for long-lasting international collaborations with the world's most important experts in medical mycology. It was there that she started studies on molecular epidemiology of Aspergillus and studying aspergillosis. Now, presently, Raquel works at the Unity of Parasitic and Fungal Infections of the Instituto Nacional Ricardo Jorge in Lisbon, being her main focus the diagnosis, vigilance, and molecular epidemiology of fungal infections. She has quite an impressive number of publications and communications in national and international conferences. And since 2019, she belongs to the European Confederation of Medical Mycology, and she is the Portuguese delegate of the international organization GAFI, which is the Global Action for Fungal Infections, and also one of the Portuguese representatives of LIFE, the leading international fungal education. Last but not least, she is presently the president of the Portuguese Association of Medical Mycology. So it's our pleasure to have her here today to give us the perspective of a national surveillance laboratory on fungal infections, and to talk to us about her work. Thank you, Raquel.
Thank you. Good morning. First of all, I would like to thank Professor Celia for the invitation to participate in this meeting. It is always a pleasure to contribute with Minho University, to cooperate with these teams, and to contribute to raise the awareness on fungal infections. So thank you for the invitation. So as Professor Celia already mentioned, I work in the area of clinical mycology and in the diagnosis of fungal infections. In my presentation, I'm going to talk about Aspergillus and aspergillosis, and I will focus on the major concern associated with aspergillosis and also on its epidemiological trends. So this is one of the research lines of my lab, and I'm going to give you some insights on the surveillance program that we are running at the lab. This surveillance program is on Aspergillus epidemiology and azole resistance. So just to give you some very light overview on fungal infections, globally, over 1 million people are affected by fungal diseases. Most people are at some point in their lifetimes are affected by fungal infections, namely by infections in the urogenital tract and or infections that affect keratinized tissues, such as skin or nail infections. On the other hand, life-threatening fungal diseases affect millions of immunocompromised patients, causing an estimated 1.5 million deaths year. And for all this, and in this context, new and affordable diagnostic methodologies and different antifungal therapies are needed. So in addition, there is also a need to strengthen public health and the research capabilities on this issue. Fungal infections can be classified as systemic or deep infections over here, as you can see over here, as subcutaneous or as superficial, and which includes also the mucosal infections. This classification will depend on the degree of tissue involvement. The allergic and chronic infections are also included in this figure over here, chronic and allergic, to highlight that the host response to the pathogen may also lead to other categories of classification. Fungal infections may be caused by yeasts over here, by filamentous fungi, or by dimorphic fungi. These ones, most of them are endemic from America or Africa. And they can change the morphology from the filamentous to yeast phase, and this change is triggered by the rise of the temperature. They are filamentous at the environmental temperature, but they change to the yeast phase at 37 degrees Celsius, which is the body temperature, in order to achieve a better dissemination through the bloodstream. So this dimorphism is considered as a virulence factor, and these are considered as the real pathogenic fungi, these ones. These ones, yeasts and filamentous fungi, most of them are considered as not as real pathogenic fungi, but as opportunistic fungi, and they affect essentially the immunocompromised patients. Among the group of filamentous fungi, the main etiological agent of infection is Aspergillus, especially Aspergillus fumigatus. So Aspergillus conidia are very, very resistant. They are produced in large amounts, and they are very easy to dissociate and to disperse in the air and easily inhaled. When Aspergillus conidia are inhaled, they may reach only the upper airways in species that have larger conidia, like for example Aspergillus niger, or they can reach the pulmonary alveoli. Aspergillus fumigatus is the etiological agent of about 90% of aspergillosis cases, and the small size of its conidia allows its entrance in the pulmonary alveoli. After reaching the alveoli, a clinical range of manifestations may occur, from complete clearance over here uh, to invasive aspergillosis. From this one to this one, there is a huge range of clinical manifestations, and the impact of the conidia inhalation and patient outcome will depend on several factors, such as the immune system of the host, the existence of previous pulmonary lesions, the amount of inhaled conidia, and the virulence of the infecting strain. And when we talk about this virulence of infecting strain, we may consider the production of mycotoxins, production of microbial volatile organic compounds, thermotolerance, and antifungal resistance profile. So in this figure over here, we can see the most frequent fungal infections and its representativeness and association with different risk groups and underlying diseases. And as you may observe, invasive aspergillosis is frequently associated with cancer patients, namely the hematological ones, and critical patients, patients with also with pulmonary obstructive, chronic obstructive pulmonary disease, and also patients infected with influenza and patients infected with SARS-CoV-2. The prevalence of invasive aspergillosis in these new groups of patients is about 15 to 30%, which is very high. So these are the main risks of the development of aspergillosis. And as you can see, at high risk are the patients with allogenic bone marrow transplant, chronic granulomatosis disease, severe influenza, COVID-19, among others. The invasive disease associated with influenza is called IAPA, influenza associated pulmonary aspergillosis, whereas kappa is the name given to COVID-associated pulmonary aspergillosis. So, invasive aspergillosis is the most serious clinical status associated with aspergillus. More than 30 million of patients are at risk for invasive aspergillosis due to the use of corticosteroids or immunosuppressors. About 300,000 patients will develop this disease annually. More than 125,000 of these patients have COPD. The diagnosis of these infections is difficult. The treatment is often too late and only partially effective. About 15% of mortality is due to aspergillosis is caused when aspergillosis is treated, but more than 99% of mortality if this aspergillosis is not treated. And the hospital costs associated with invasive aspergillosis are much higher than the amount spent in hospitalized patients without aspergillosis. So these are the most frequent etiological agents of aspergillosis: Aspergillus fumigatus, Aspergillus flavus, terreus, and Aspergillus niger. And as I said to you previously, Aspergillus fumigatus is the most frequent agent of all. So until now, more than 400 Aspergillus species are described. These species are taxonomically distributed among sections. As you can see here, each section is represented with a different color. Within each section, you can observe different species that are morphological identical among them, but when these species are analyzed to molecular level, we verify that they have genetic differences, and these differences are translated in differences in their virulence and also in their antifungal resistant profile. So these species that have morphological similarities but genetic differences, they are called cryptic species. So within, for example, the Fumigatus section, we have the Aspergillus fumigatus sensu stricto, which is the real Aspergillus fumigatus. And then we have its cryptic species, such as Aspergillus lentulus, Aspergillus udagave, Aspergillus felis, and much others. So Aspergillus resistance has become an emergent concern of the scientific community. And when we talk about resistances, we have to consider a primary or intrinsic resistance, or when all individuals of the same species are resistant to a specific antifungal. And examples of this resistance occur exactly in several cryptic species. For example, within the Fumigatus section, Aspergillus lentulus is intrinsically resistant to several azoles, whereas Aspergillus fumigatus sensu stricto is, in a general way, susceptible. The emergence of acquired resistance, however, the emergence of acquired resistance is in Aspergillus fumigatus sensu stricto has become a major health concern. So, besides the intrinsic, we may consider also other modes of resistance, the acquired or secondary resistance, when only some isolates of a certain species are resistant to a specific antifungal. This acquired resistance may occur to the selection of resistant isolates during the antifungal therapy or prophylaxis. As you can see over here, the antifungal substance exerts a positive selective pressure towards the strain that shows resistance to that antifungal. The secondary resistance may also occur due to the selection of resistant isolates by the use of azole fungicides in crops. So these pesticides have azole molecules that that are similar to the clinical azoles, and therefore there is a cross resistance between when the patient inhales a mixture of resistant and susceptible conidia and is further subjected to azole therapy, and this treatment may therefore fail. This environmental azole resistance is caused by specific point mutations in the CYP51A gene and also caused by tandem repeats in the promoter of this gene. And these mutations are associated with a resistance to all azoles. And as you can see over here in this figure, there is an emergence of multi-azole resistant isolates. So these are the known mechanisms of antifungal resistance. Mutations in the CYP51A gene are the most frequent cause of Aspergillus fumigatus sensu stricto resistance, and the CYP51A gene encodes a protein enrolled in ergosterol biosynthesis. So point mutations inside the CYP51A and tandem repeats in its promoter may lead to resistance to one azole or to all azoles in case of mutations also in the promoter of the gene. So besides this type of mutation over here, you can have also other causes of resistance, such as biofilm production, multidrug efflux pump overexpression, or CYP51 expression overexpression. Given the rising concern on antifungal resistance in Aspergillus fumigatus, the European Centre of Disease Control has published several recommendations on this issue, as, for example, to improve the epidemiological surveillance on Aspergillus, to investigate the environmental origin of resistant isolates through environmental and laboratory studies, and also to develop molecular methods to detect triazole resistance. So, in this sense, our National Reference Laboratory, whose main activities are listed here and go from training courses to reference diagnosis and research, our lab established a national surveillance program on Aspergillus. In that program, two main studies were conducted, and one of them was performed in the periods of 2017-2018 and aimed to study the molecular epidemiology of all Aspergillus isolates received in our lab. Our goal was to understand species epidemiology, distribution, and prevalence of cryptic species. The other study includes the periods 2012-2019 and aimed to study the antifungal susceptibility profile of Aspergillus fumigatus isolates to determine the percentage of resistant isolates, and also to understand which molecular mechanisms are enrolled in the resistance of the detected resistant isolates. So, in what concerns to the first study, we analyzed 2,056 Aspergillus isolates and 156 from clinical and 99 from environmental sources. And to obtain those isolates, the biological specimens were inoculated, incubated, and then the obtained colonies were observed. Macro and microscopic features were analyzed, and Aspergillus colony were then re-isolated into new media. After culture and purification, DNA was extracted and calmodulin and beta-tubulin genes were sequenced in order to attain species level identification. Regarding the 156 clinical isolates, they were collected from 14 different hospitals distributed throughout the country, and they were collected from 129 patients. The most frequent clinical manifestation of those patients was the prevalence of bronchiectasis in their imageological exam, and the clinical specimens from where Aspergillus was collected more frequently were bronchoalveolar or bronchic lavage. So from the 156 clinical isolates, we identified 25 different species by Aspergillus species by sequencing, with 37% of them being classified as cryptic species. We also detected cases of mixed infection and colonization with different Aspergillus species in those patients. In 4 cases, Aspergillus fumigatus and Aspergillus section nigri were isolated from the same biological product. Several patients were also infected with or colonized with the Aspergillus fumigatus sensu stricto and its cryptic species Aspergillus lentulus. In other cases, Aspergillus terreus was isolated from 7 patients together with other Aspergillus species. And this is important to highlight because in these cases, co-infection with a less susceptible or resistant species may lead to therapeutic failure. The molecular identification of Aspergillus to species level is very important and is highlighted in this recent ITSA guideline, where it is mentioned that Aspergillus collected from deep infections should be identified to species level by sequencing. This will allow the identification of possible cryptic species and the identification of possible intrinsic resistances. So when we compare the group of our clinical isolates and the group of environmental isolates, we observe that in both groups, Aspergillus fumigatus was the most frequently isolated species. We identified, as I said previously, 25 different species in clinical isolates and 18 different species in environmental isolates. We also identified in the group of environmental isolates 50% of cryptic species, more than in the clinical group. And these differences were statistically significant. So, in order to study the antifungal resistance profile of Aspergillus fumigatus, not sensu stricto, fumigatus and its cryptic species, we decided to enlarge the study isolates, and we all fumigati isolates collected in the period 2012-2019 were analyzed, and from those 319 isolates were identified as Aspergillus fumigatus sensu stricto, and 18 were identified as cryptic species belonging to the fumigati section, like Aspergillus lentulus, Aspergillus felix, or Aspergillus udagave. So the frequency of cryptic species in Aspergillus fumigati was about 5%. To detect possible azole resistances, all fumigati isolates were then screened in azole supplemented media, as you can see over here. We used itraconazole, voriconazole, and posaconazole with a defined concentration to perform this screening. And we detected growth in at least one of these zones in about 46 sensu stricto isolates and 7 cryptic species. And all those isolates were then analyzed using broth microdilution reference methods to determine the minimal inhibitory concentrations to voriconazole, to itraconazole, and to posaconazole. And this is the reference method that we used, based on CLSI M38. So these are the obtained results. In orange, sorry about this image, it's too full, but what I want to show you is what is in color. In orange, we have the supposed resistances to the antifungals. In yellow are the ones that are considered as with intermediate susceptibility, and in white, the ones that are considered susceptible to these antifungals. And as you can see, some isolates showed resistance to the 3 tested azoles, as you can see over here. So these results allowed the determination of a frequency of 4.4% of resistance to itraconazole and 2% of resistance to posaconazole and voriconazole. Those isolates with high minimal inhibitory concentrations to those azoles and considered as resistant were then analyzed to molecular level to unveil the associated mechanism of resistance. To do so, the CYP51A gene and its promoter were sequenced to detect point mutations and tandem repeats, and in parallel, a target real-time PCR was ran to detect the most frequent mutations associated with azole resistance. We therefore concluded that the overall prevalence of resistance to azoles in Aspergillus fumigatus sensu stricto was about 3%. The TR34L90H mutation, which is a tandem repeat of 34 base pairs in the promoter of the CYP51A gene, and a point together with a point mutation inside the gene that leads to the substitution of a leucine by an histidine in the position 98. This was the most frequently detected mutation in 1.4% of the cases of the isolates. This mutation is described as being associated to acquired environmental resistance, and it was found in 3 environmental and in 1 clinical isolate. In all these 4 cases, this mutation conferred a pan-azole resistance, which means that those isolates were resistant to all azoles. The substitution, the mutation G54R, which is a point mutation inside the CYP51A gene that leads to the substitution of guanine by an arginine at the position 54, and which is associated with an acquired resistance due to prolonged prophylaxis, was detected also and curiously in an environmental isolate, and conferred an in vitro resistance to itraconazole and to posaconazole. The 6 tested cryptic species showed high minimal inhibitory concentrations to all triazoles. Several isolates displayed minimal inhibitory concentrations higher than the proposed epidemiological cutoff values, but no mutations were found in the CYP51A gene or in its promoter, and therefore alternative resistant mechanisms may be involved, and we are going to address this issue in soon. So to conclude, I would like to just to reinforce some points. The first is that the understanding of the shifts in Aspergillus epidemiology and of the local resistance patterns is needed to manage therapeutic approaches. From the studied Aspergillus, a very high percentage of cryptic species was found. From our lab collection of Aspergillus fumigati isolates, more than 5% were cryptic species. From those, almost all showed resistance to azoles, and 3% of Aspergillus fumigatus sensu stricto showed resistance to azoles, being the TR34 L98H, the most frequent mutation. So this study was published in January 2021 in the Journal of Fungi, and before finishing my presentation, I would like to emphasize that the obtained results are consequence of a study of isolates that were collected and provided by a group of researchers, and these are also co-authors of this presentation, and these are their names. And at least I would also like to leave you with these websites that have a lot of information on fungal infections worldwide, if you have interest on this issue. And finally, I would like to thank you and for once more for your attention and for the invitation. And I'm available to further questions. Thank you.
Thank you, Raquel, for your presentation and to give us this perspective of fungal infections are, or at least aspergillosis and aspergillus are really important in our country, and how laboratory like Ricardo Jorge can help to give insights on the situation, the epidemiological situation in Portugal. Now we are open for questions. Does anyone want? So I can start about the one of the most relevant things that you refer is the presence of cryptic species, and how now how is this working in real life? I mean, in the hospitals where patients are do the diagnosis takes in account the molecular identification of the isolates, so that that can influence the therapeutics.
Well, the majority of the hospital labs do not have the facilities to do the sequencing of the isolates. When they have some hospitals are aware of this problematic, and they can send to our lab to do the sequencing and to detect if it is a cryptic species or not. Of course, that in cases of an aspergillosis without clinical response, the clinicians think in what can be wrong, and they can send us the isolate. Sometimes they phone us and ask if they can send us the isolate for susceptibility tests or for molecular identification.
Mhm. Okay, so one of the things you referred is for high risk of aspergillosis is COVID-19. Do you have any data already in the Institute Ricardo Jorge
Oh,
about this? Do you have any numbers in Portugal or
no.
around the world of what is happening?
In Portugal, no, we don't have those that information yet. We are doing some work on spreading this new information, because it's a real new issue and a hot issue at the moment, and we are trying to raise the awareness of on this. Um, and we already received some isolates or to do the sequencing and susceptibility of COVID-19 patients, uh, for one hand, and in the other hand we also received some products such as bronchoalveolar lavage or serum to detect galactomannan, for example, which is one of the antigens that is detected in cases of invasive aspergillosis. And the clinicians are starting to be aware of this new disease, this entity, and there are no numbers yet, but I think that maybe in soon.
Yeah. Maybe in many cases it's not detected. Um, so, Carlos, I have one. Yeah. You have one question from Carlos Vedor. Can you in the chat, Raquel?
Let me just.
I can read it if you want. But Carlos, you
Yeah,
are
I
able
can.
to unmute yourself if you want.
Yes, you can.
Okay,
Yes,
thank you. I'm
yes.
sorry. Can you hear me well?
Yes,
Yes.
yes.
Okay. I wanted to ask you if during the identification of the resistant genes, you were also able to identify genes that are involved in the virulence mechanism and if you when you are studying or you are making differences in the species, if you found out some species that were more aggressive to the patients than others. And also, one second question was if there was any less research antifungal that could be used to treat severe cases of resistance when you find those types of resistance to the most common drugs.
So we have not studied virulence factors. We also search for susceptibility profiles and for mutations that confer resistance, but is one point that we would like to address in close future. And regarding the other question about the antifungals that can be used when these ones are not working, there is, for example, amphotericin B together with some echinocandins that can be used instead of azoles.
Thank you.
Thank you for the questions.
I don't have any further questions for now.
Are there any more questions? No, apparently not. So I thank you again, Raquel, for being with us in Science on the Screen. Thank you for your presentation.
And thank you for the invitation. It is always a pleasure.
And thank you to, yes, to come to your former lab.
Yeah.
Okay, so and I thank you all the participants, and have a good day.
You too. Thank you.